not a lot of people just meet like that.
Oh, okay.
So there are other meetings that are, there's the Pure JM meeting, which is for families and it's for children with myositis. And they do have like adolescent young adult sessions at their meeting too. So you'll get many more individuals who had it or still even have it that are moving. So I just thought I would start with going back and talking a little bit about the disease condition that, you know, if you had them as a child, you probably, you know, were oblivious to it right at that point in time. So talking about what juvenile dermatomyositis is and thinking about it as you become an adult, sort of how is it affecting you. So there's no question, similar to adults, but we really think it's different in many fashions, and I'll describe some of that to you. So when we're thinking of dermatomyositis in a child, juvenile dermatomyositis, usually there's a couple different things that we see, right, patterns, just like an adult. We see that there's some rashes that look like the redness. We see the redness around the fingers, I talked about the Gaucher's rash, and we see the nails that have these swelling of the blood vessels. And then this is a picture of muscle when you get inflammation in very specific places in the muscle if you take a picture, if you do a biopsy of the muscle. We also know that there's some very classic rashes that we see. Similar to adults, but you might see some different in children and some maybe more common in children. Like the redness that happens around the face. And I think that somebody talked about earlier today that this is sort of, you don't get as much redness right around the lips. That's kind of spared, which is unique. You get redness around the eyes. It's called a heliotrope rash that you see around the eyes. You get the redness and the scaling over the knuckles and places like that, and the elbows and the knees. And then you start getting also swelling of the nail beds. You also can get ulcers. Children will have ulcers under their arms sometimes, in areas that somehow have gotten rubbed or something like that, like elbows will get the ulcers that can occur. And then you can get redness on the areas that kind of, we call them extensors. So they're kind of the areas that are straight on sort of your limbs. And then you get this redness around the nail beds. And it really is caused because you actually get swelling of the blood vessels. So you see that there's like a little, the blood vessel comes up here, makes a turn, and comes back. And normally it's really thin and totally in line. And what happens is you get swelling of it. That swelling of it actually is something called vasculopathy, where the blood vessels are getting irritated and swollen in here. So the clinical symptoms we see in juvenile myositis, like you said, I started with that the most common are skin findings and then the muscle findings. And usually they can come together in like 40, 50% of the cases. But in the other cases, sometimes the kids get weak first. And, you know, there'd be signs like not being able to climb up the stairs or do things you used to, and kids don't know why. So often, you know, they can't do things they don't know why. Or they can get the skin first. And when the skin comes first, often people think they have eczema or something because of the way it really looks. But there's many features. Children get lung problems as well. They get GI problems. And when they get GI problems, what we get worried about is if they have a lot of pain or ulcers in their GI tract, that actually can lead to them opening up or perforating, and that can be quite life-threatening if that would happen to children. Other things children get more commonly than adults is calcinosis. You hear about that a lot. And really what it is there's all kinds of calcinosis. But what happens is you get calcium, like there's a little white dot here, there's white, oops. What happened? I don't think it's because I touched the screen. That's really strange.
Started.
Huh?
Yeah, I don't think it's because you touched the screen either. I think it's stuck.
Something is restarting in the system.
Yeah.
But anyhow, there's like calcium in here. And then these are pieces, this is an MRI of your muscle, cutting through your muscle. And these gray bundles are your muscles, right? They talk about your quads and your glutes. And then the white is calcium. So it's calcium that's coming around the muscles. And sometimes it's hard calcium, sometimes it's liquefied, but toothpaste kind of calcium. And that can cause a lot of discomfort and restrict your muscles. So different than adults, because I'm going to go back and forth a little, because you're hearing all adult stuff primarily here, right? Adults have many similar features, but adults have other problems. They get like heart failure because they've had other things that go on in their body. Much more lung disease happens in the adult side of things. they get less of the GI tract. So they get swallowing problems, but less of the GI ulcerations and vasculopathy that does occur. So it's somewhat different. Adults can also have those like heliotrope rashes, a lot of swelling, much more intense, that can be seen, much more prominent, that can be seen. They also will get more of the shawl rash. We rarely see that when you're a child. We rarely have that when you're kids. And unless you have the synthetase, which we're talking a little bit about, usually don't get mechanics hands. It's again, less common. Doesn't mean it doesn't happen, but less common. And then we also can see some Raynaud's, but maybe a little more common in the adult side of the street. So if we compare the juvenile and the adult side, and we think about the proportionate cases, most children who have myositis have juvenile myositis. In adults, it's only a portion of them because they have necrotizing myositis. Adults can have IBM, which is what a lot, even though we think that's very, very different than what we're talking about, a different immune kind of mediation. And in children, it's incredibly rare to have that. So dermatomyositis is the most common thing that we see. We get more calcinosis in children than you see in adults. About the same, can become refractory, but we actually think we do a better job of really getting it into remission. And then what we see is we see rare malignancies associated with it. That's much more of a finding that you see in the adult population. More lung disease in the adults. We get more GI disease in children, and mortality is much less in children than it is in adults, particularly in this day and age. It's our ability to treat aggressively. So these are kind of the classifications of myositis. Like I say, in adults, they have polymyositis, dermatomyositis. In children, it's almost always dermatomyositis. We do have some children with polymyositis. It's very, very rare to have them, but we can see it sometimes, and it's very specific who we see it in, and there's a specific antibody that we sometimes see it with. But then there's myositis that sometimes is with other diseases, like mixed connective tissue disease. A lot of people talked about that today, or overlap disease. You can see muscle disease with that too. Inclusion body myositis, and then the necrotizing disease, which is very specific of what we see on a muscle biopsy to see that. So juvenile myositis is seen in around 1 to 200 to 400,000 people in the U.S., higher in Hispanics and African Americans overall, and increased incidence based on geographic group too. They think the closest you are to the equator, the higher the incidence of the disease, kind of making you think how sun maybe could be precipitating some of the disease. There's criteria we use to define it, and these are criteria that's been around since the 1970s, long, long time. And they've actually just been recently revalidated. We looked at thousands of patients, and actually they still hold true, but we've added a few things. So we look for muscle weakness that's symmetrical, so even on both sides, which is usually the case. It's usually much more proximal, means closer to your trunk, and less in this. You heard a lot today about people with their hands, very unusual with pediatric disease and dermatomyositis. And then we look for some evidence in your blood of muscle enzymes elevated, which means you have irritation of the muscles. And then we look for some other tests, like a EMG, some people have had, or muscle biopsy. You know, both are good tests. EMGs people aren't doing as much anymore. There's less people that are really skilled in doing it, but you can get a lot of good information from it. Muscle biopsy, I mean, you've got sort of a tissue in front of you to see, but the disease is not uniform in your muscle. So it actually, sorry, I just keep trying to, this, oh, it's doing that. But it'll be like in different areas. So sometimes that's why people say when you go in to get a biopsy, you have to have a nice size, because you could miss the lesion, you can miss the area if you just go randomly in to biopsy. And then the skin are some of the classic things we talked about, the Gotrins, that rash over the knuckles, red rash on your face, you can lose some hair, alopecia, and then the calcinosis. But some of the new findings that are in the new criteria are doing an MRI. An MRI shows you edema, so it shows you edema. Now edema means just water in the tissue, and it doesn't have to be from myositis. If you got hurt, like somebody hurt you really bad, or let's say you went and ran a marathon, you can get edema in your muscles. So you kind of have to know that it's not 100%, But if you do see it, it's very suggestive of it. The other part of the criteria are these blood vessels that we see dilated. Those are called periungual telangiectasia. That's another part of the criteria that's been added to the system. Also the genetics. So this isn't a disease that a gene causes, but we know people with certain immune response genes actually are much more likely to have it. So for example, studies that we've done looking at Caucasian, African American, Hispanic patients in the US show that 86% had specific genes that are certain kinds of immune response genes. And normally in the population, it was around 30%. So it's much, much higher. And the adults are similar, they just have some that are a little bit different than the pediatric population. And what we think is that these genes actually make your immune system quite robust and quite active, and so you respond to things more. And the thought is maybe it's become overactive at one point in time, and that's what kicks the disease off, because your immune system is so robust. Many people who get the condition as a child, their families say, well, they're the healthiest one. Well, that's because your immune system is really good. It probably was. In this case, it kind of went too far, got too aggressive, and kicked off the system. The other thing we do in pediatric population particularly is you try to think what else could this have been. So I'm sure your doctors did that as a child and said, well, could you have another connective tissue disease? Could you have a metabolic disease like thyroid disease or something like that that's causing your muscles to be bothered? Could you have other nutritional problems that are causing your muscles to be bothered? Neurological conditions, so there's something called Guillain-Barré or ALS is Lou Gehrig's disease in adults that you see. In children, muscular dystrophy, which would not be the classic phenotype, it's usually a boy that would have muscular dystrophy, or myasthenia gravis. Also, did your body get exposed to alcohol, to something that would have made the muscle break down? And that's all the stuff your physician had to kind of put together for you to kind of see what could it be from. In children, we don't really think they're cancer related. That's very much an adult thing, but we do think about infections. There's certain kinds of infections that we know can target the muscle, like Coxsackie virus and other things, and all of that is taken into play when you're trying to diagnose. Also, if you're thinking about other connective tissue diseases, this is where we look at overlapping disease. You heard people talk about mixed connective tissue disease, but you can get muscle inflammation in scleroderma, in sarcoidosis, and polyarteritis, and lupus, and juvenile arthritis. They can all cause muscle disease, but it looks different than myositis muscle disease. If you were to do a biopsy or see how what happens over time, it actually acts differently. And your physician would have been thinking of all of that stuff. But we do see other overlapping autoimmune diseases, sometimes celiac disease, sometimes diabetes, which is what IBDM is, or thyroid disease you can see. So what did people do for diagnoses? We do muscle enzymes, and in children, we know that the most sensitive are some of the muscle enzymes like SGOT, which is AST and ALT. I don't know if you get your muscle enzymes drawn. Less sensitive is CK, aldolase, and LDH. However, as time goes on, the most sensitive enzymes to test is the aldolase and the LDH. After you've had disease about 6 months, your CK is much less of a marker of disease. And especially in children, it kind of goes away sometimes, and it's not even there, but you still have muscle disease, which confuses people sometimes because it's gone. Your sedimentation rate, is it helpful? That's a marker of inflammation. Sometimes it's up, sometimes it's not. So we don't follow it. People do have tests like ANAs, which is an antibody test, quite commonly is positive. But the other antibody tests for like lupus and stuff in here are negative, most commonly. Occasionally you'll find some overlapping. But what we do see is that your myositis antibodies do end up being positive in a good portion of the patients. This is just the oddest thing I've ever seen. It keeps going off. I wonder if the system is trying to drive it somewhere. Other tests that probably you had is maybe that Emg test, and that can be positive in about 90% of patients. Biopsies in about 80%, and it's because I told you it was kind of localized and focal. And people do in pediatrics like to use MRIs to guide where to biopsy because your chances go up quite a bit of making sure you're in the right place. There's also some other newer stuff. People talk about something called a SPECT scan, but it's very, very costly, and most places don't do it. Most places just do the other scans. So if you looked at your biopsy, let's say, this is your muscle, the red is the muscle, the dark dots are the nuclei or inflammatory cells of the muscle as well. And when we see it, what we see is a lot of activity in the muscle. It's not a quiet organ, it's got a lot of activity. All these different markers show up in the muscle tissue. So you got all different kinds of cells that show up, you got all kinds of proteins that the cells are making show up, and so it's like almost like a fruit salad. It's all mixed up with all this stuff in it, and so it's a very robust immune type of environment that is there. We talked this morning about MHC class 1 upregulation. It's also called HLA class 1, same thing. Happens in the tissue, which tells you the tissue is stressed or perturbed, and then that's acting like an immune attractant as well in the tissue that goes on. Also, when we look at adult versus pediatric populations, this is really busy, I know, but the point to tell you is that DM is adults and JDM is kids. And what we see is when we look at different protein markers or immunologic markers, there's a difference. Like in adults, this one is lower, this one's higher in children. Same thing for this one. In some of the other ones like this, the adult's higher and lower in kids. So it's not the same disease. It acts very differently. And I think it's really important because the response to treatment can be different in the outcome. We have much better outcome in the pediatric when it starts as a child than you do as it starts as an adult. This is also showing you sort of this patchwork, but this is showing you the first line is the adults patchwork, and this one's the children at the start of their disease, and you can see the patchwork looks differently. So this is telling me that there are different parts of these proteins that are immune proteins that are getting elevated in adults than in children. Children have different ones. And that even the next two columns show you what happens in adults and children after they've been treated. And again, you see variations. So it is, we think immunologically it can be quite a different disease. The parts of the immune system that are involved, the two main parts, are, one is called the innate immune system here. The innate is sort of the frontline defense. If something happens and stresses your system, a trauma, you start to get a virus, or things like people with gout, you start to get some crystals, it causes that part of the immune system to react right away. And it starts to sort of defend you. And then the part that comes along and gets educated that kind of stays with you is called the adaptive system, which is here. And it is, again, a whole bunch of different cells that get educated themselves, that actually stay with you. Remember that you've had inflammation. They're the cells that get activated when you've had an immunization. And they remember about the immunization.
Yes,
Yep.
so I was diagnosed when I was 4, 1984. My mother said I was fine. She said what happened, I got a shot.
Yeah.
One of the shots.
Mm-hmm.
And she said after that is when I got sick. Like not far after that.
That you got sick.
Maybe a few months to a year.
Yeah.
But that's when she said I got sick. And the marker was I was a rag doll. That was her explanation.
You couldn't do anything.
Come to my legs.
Yeah.
So they had to like pick me up, shower me, everything. Then I went to Children's Hospital at Mount Sinai Children's Hospital in New Jersey. First North Beth Israel, then Mount Sinai Children's.
Yeah.
And that's where I was diagnosed. So it was the shot. Like it was but that's what she said.
Yeah. Well, I don't, so I'm not saying the shot did it, but we do know when you get an immunization, it stimulates that part of your immune system. So it could have been your background was, the genes were there and everything, and it was just that signal or something made it even get bigger. And that, we actually think is sort of a bunch of things that come together at the same time, not just one thing that happens. Could very well be.
But that's why a lot of parents don't like to give their kids shots in like the immunizations now because of the possibility of things like this.
It does, but I'll go on my other side, put my other hat on as a pediatrician. The chance that you can have serious outcomes of disease or infections is much greater than shots producing something like this. It's much less common to have that happen.
Oh, it keeps
All
going
right.
off.
It keeps.
Maybe you're not connected to the internet?
I'm not supposed to be.
Oh, okay.
I'm not. It's like trying to cycle, but it won't let me take it off of it.
It keeps doing that, going in and out.
Here. No, it's not going to let me. Okay. And so this is just what, like, this is a picture of muscle, and all these green and yellow are different cells that are in the muscle, the kind of muscle that you would see. And that's why it's kind of all those different cells are there together, kind of all together activating each other, stimulating each other to keep going. This is a list, and I know you can't read it, so don't worry. You're not supposed to be able to. This is a list of antibodies. You know, we talked about antibodies today, and I'm going to go into that in more detail. And we talk about the antibodies in this column in children and this in adults, and what you find is they're present in different proportions. Some you see almost always in adults, and some you see more in children. And it does seem to matter because the clinical features and outcomes are different. And we'll go into that a little bit now, talk a little bit more about it. So this is actually talking about many of the different antibodies that we see here on the bottom. And what we've tried to do is actually put them into categories. So one category you heard about that we now use is called antisynthetase syndrome. Those patients can have classic dermatomyositis or polymyositis, but they have very similar symptoms, and this is many of the different types of antibodies. Then there's what we call necrotizing, which is where you have very little inflammation, but there's muscle breakdown. And this is the one, particularly SRP, that can be seen in girls, particularly, and particularly African-American girls in the United States, and they get sick really fast, and it's mainly muscles, they don't have skin, and it can bother their hearts. And then we get what we call amyopathic, this one, and that's where mainly you get rash, and then it takes a long time for muscles maybe to be involved, if at all. And that's a whole group. And then there's the classic dermatomyositis as well that's there. And I'll show you the next one. And this one kind of says, okay, so if you're more likely to have skin disease, you're more likely to have one of these antibodies here. If you have malignancy in adult, you most likely have one of these antibodies there. If you have lung disease, you either have the MDA or one of the synthetase antibodies that allows us to categorize, and it's really, really helpful because for the first time it's allowing us to say, oh, if you have this, then these are the things we really need to watch out for before we come at it all, because you really didn't know. And now that we're finding these antibodies that are present, it's been very, very helpful. Did you have a question? You look like you're going to ask me something. Okay.
I have a question.
Yeah.
So so I had juvenile dermatomyositis, and the doctor said I would told my mother I would garage. I don't know if you should have said that. Do you think? So, okay, that's one question. So do you think, in your professional opinion as a pediatric, do you tell parents that their kids could possibly grow out of it?
So
that's what he told my mom.
We do know that a good portion of patients go into remission,
okay,
and actually can do quite well and not have signs come back.
Okay.
That does happen.
Okay.
I think it happens less than we thought many years ago.
Okay.
You know, way back before we treated,
Okay.
way back in 1950,
Okay.
a third of children died. A third of children were so disabled they couldn't walk, and about a third of kids were okay. They did pretty good, right? And then they started using steroids and, you know, all these other drugs, more recently methotrexate and stuff, and all those numbers have kind of changed. Where there are about 30% of kids, 40% that do extremely well. You treat them, it's gone. They really don't have signs or symptoms of it. And we have then about 20% that are really sick and never get better. Then you have the rest, right, the 50%, who get better. It takes them multiple years, but sometimes things kind of come back a little bit, it goes up and down a little bit. And so that number is probably bigger than we ever thought. Doesn't mean it still can't go in remission and potentially finally settle off and stop. It can. It's just not as easy and simple as we thought.
Okay. So that's my one question.
Yeah.
And my second question is, later on when I went to Johns Hopkins, they said that I had the autoimmune necrotizing myopathy.
Okay.
Now I think, looking at the symptoms of IBM, I feel like I have that, and I'm going to talk to my doctor about it.
Good.
So what's the possibility of it going from JDM to dermato? Because I had the skin, but I haven't broken out in a long time. To autoimmune necrotizing, and then possibly, can it go through all that?
No, not that we know of. I mean, unless something else came in and hit you with it. So if they felt that you had necrotizing,
Yeah.
so did you ever have skin at all?
I did. I used
So
to
that
have
would
skin
be-
back
okay.
here on my everything,
Yeah.
except for my face.
Yeah.
Here,
Yeah.
here, my knees, my legs, I used to have it bad.
And have they ever done antibody profiles on you to see if they knew what your antibodies were?
Oh, I don't know.
Because that would help you know, because different antibodies, and here, let me show this to you, actually have different features. Okay. It's just not letting me turn this off. Okay, so I told you there was a group called anti-synthetase antibodies. That's JO1 and some other ones. And that's much more common in adults. Very rare in kids. We don't see it very much, but we can see it. Patients who have it often can have severe muscle problems. They get lung disease, interstitial lung disease. They get arthritis. They've got swelling of the joints that occur there. They can develop those mechanics' hands and roughness and gray nose. And so that's sort of the features that those patients usually have, whether you're a 5-year-old or 30-year-old or a 50-year-old, but we just don't see it as much in kids as we see some other forms. There's one called TIF1 gamma. It also is seen about the same in adults and kids, maybe. Patients have a lot of rash, like this little girl over here, this face, she's got a lot of rash. And sometimes you can have things like this rash that looks like psoriasis on the hands, but it's a dermatomyositis kind of rash. It looks like psoriasis. You can get ulcers sometimes of the skin, and then you get something called lipodystrophy, where you get fat distribution changes, where you lose the fat sometimes in your arms and legs, so it looks really muscular but thin, and you get more around your belly. And that's because the fat changes, and that's a phenomenon we see in a couple different conditions, but in dermatomyositis we can see it as well. One of the other ones is NXP2. This is one that's seen much more often in children, they think, than adults. And when we see it, kids are much more often going to have calcinosis. Also, this is one that usually happens where you get sick really fast, and kids can get very, very ill, like have to be on a respirator for a while and everything, because they get so weak if you have this antibody. Another one's MI2. We see more in adults than children, but people can have very intense rashes with this one that can show up, and very sun sensitive, very, very sun sensitive. So you're out in the sun just a little bit, it can flare up. And then the last one that I'm going to talk about is called MDA5. MDA5 antibody we see in children much more than adults, unless you're an Asian descent, children or adults. It's the most common antibody. So I was just over in China visiting and doing some work in myositis, and almost every child who had the disease had this antibody. It was very prevalent in that part of the country. These children often start with skin only, and they have very little muscle disease. They have to be watched carefully because they can develop lung disease quite significantly, quite fast. So we have to watch them. They start with the skin, that amyopathic one, and then the muscle disease can start really quickly. So we watch them very carefully if that's the case as well. So see, these antibodies, why I'm asking you, is antibodies can help predict sort of the way to go. And depending upon, which one maybe you had or you have, if it hasn't been checked, it might be really very important to try and check it to say, do you have one of these, or do you have one that looks more like that necrotizing myopathy, which usually does not have skin disease with it at all, that SRP and stuff. That'd be very unusual.
Yeah, they said that Johns Hopkins, when I went to Johns Hopkins, she said, I have that now. Autoimmune, that's. And
she did it based on your muscle biopsy, because you have to do a biopsy for that.
She didn't do a biopsy, no.
Okay.
Biopsy where I would have to get cut, right?
Yeah, a piece of your muscle would have to come out.
She mentioned an antibody, but I don't know. But the thing is, I still I would break out with the rash a lot. So I don't know where she got that from, but that's what she said. But like I said, with the IBM, I'm gonna talk to my doctor about this. But with the IBM, I'm just seeing like my symptoms, and I'm just feeling like, I feel like this thing is so rapidly like changing. I don't know why. For the past 10 years it's been going. I went from, being able to climb stairs and do this the past 10, from 2009 to 2019, I have to say that it got progressively worse. It's slow. Has somebody gone back and redone a biopsy or anything to see if your tissues have changed? Because you do wonder, because back in 1980, you said 84 when you were diagnosed,
we didn't have all the tools we have
That's
today.
true. That's true.
So we didn't have all these antibodies identified at all,
Yeah.
right? And so we didn't have a lot of the tools even in the laboratory to look at your muscle and say, wait a minute, maybe we thought it was dermatomyositis, and actually now with some of the new things we can test, it's actually this. And that might be very helpful for you to find that out. A muscle biopsy and myositis antibodies would be really important to find out about, to see. And then one of the things, if you looked at, and this is just an example, I know it's complicated, but if you look at the antibody subsets, remember I told you that one was called TIF1 gamma, and then you look at those HLA genes, remember I told you were very prominent in pediatrics, in certain diseases. The TIF1 gamma, adults versus children, actually have different HLA genes that are positive, which makes us sort of get back to the fact that we think it's actually different conditions potentially, or triggered by different things. So it could be in adults it's triggered by one certain thing, and in peds it's triggered by something else. And I think that that's an important component. Also, when we think about treatments in pediatric and adults, we have the same similar drugs, we just sometimes use them in a little different strengths and orders and things like that. In children, we start out with steroids, which I know are not the nicest thing, but they do work incredibly well. We still do that. And then we use things like methotrexate, which maybe you've been exposed to, and IVIG. I know they talked a lot about that earlier, about IVIG. And we know that those things, and sometimes people use just like steroids and methotrexate, and if you're more severe, they'll add IVIG. In adults, they usually start with steroids and either methotrexate or something called Imuran or azathioprine. They usually start with something like that first. And then we add in pediatrics very quickly, after a few months. If you're not getting better, we add something in because we want you to start getting better. So we'll add things, if you're not on IVIG, immunoglobulin, we add it. We jump into using rituximab, tacrolimus, Cellcept, all these drugs you probably have heard of over the years. Then we jump in to add those in. And then there are things that we have in addition, like there are some special cases you have to use some of those drugs called anti-TNF drugs. The ones that you hear about in arthritis, we sometimes use those. We sometimes use cytoxin or cyclophosphamide if your disease is really bad, and especially if you have lung disease, sometimes that's really important to do. And there have even been some children who had bone marrow transplants from it. You have to be pretty sick to have that, because it truly, I mean, bone marrow transplants can also make you quite ill, but there are some cases where it was so bad that that's what they chose to do, and it did help the patients do that. So, but as you probably remember, maybe not, as a child there's a lot of effects of steroids. As an adult there's too, but as a child there's even different ones that we think about. So there's no question you can gain weight, and the gaining weight, again, around the middle is the worst part, right? And in your face, right? The other one. You can get some things like some diabetes type of things from using it. You can also stop your growth. So for children, once you use that, it actually affects your hormones and it stops you from growing until you get down to a low, what?
I said not me.
Not
I'm
you.
6 feet tall.
Well, but it might have, back then it might have, and then you maybe took off after that. So it could have, no question. If they used them high dose long enough, it would have stunted your growth. It would have. You also your bones can get more brittle, and osteoporosis can happen. And believe it or not, steroids, if you use too much steroids or the wrong doses, you can actually get muscle involvement from that. So we have to kind of watch that over time. And then your skin, when you're on steroids, you get bruised easier with your skin, and then you can get stretch marks, right? Which nobody really wants, but that can happen as well with the steroids. You can get cataracts in your eyes, and glaucoma can occur. You can get hypertension from it. It can, obviously, it lessens your immune system, you get infections, and then they also can make people grumpy and really get very moody and things like that, and it's the medicines that are doing it often. So they're not drugs that we want to use in isolation and, in high doses for long periods of time, particularly in children. So you'll notice when we've treated children, we will start them on something else like methotrexate or something else so we can get them off the steroids. In adults, sometimes they keep you on steroids because you're already grown, you're already there, and you still have side effects, but not quite to the same extent. So they often will let you be on it and stay on it as well.
So I have a question. So for the and like she said she was diagnosed at 5,
Yep.
so I was 4, so that's like in the So the only thing I know the doctor had me on was prednisone.
Yep.
And so I guess once I did gain the weight, thank God my hair didn't fall out. But so I can say that I've been on and off prednisone since I was 4, like on and off. But when I was stable in middle school, high school, and all that stuff, I think I was off because I was stable. So I feel like it was, looking back now, I feel like, oh, I was in remission because I was like playing basketball in high school.
Yeah.
So my question is now, like I'm on prednisone. The doctors have said to me that some of the muscle scarring, the muscle atrophy is from what you said, that prednisone.
Yeah, toxicity.
Toxic.
Yep.
Yeah, so it can come from that. So wouldn't I have to be on a higher dose for that to happen, or is it is it measured by the amount of time that I've been on?
So there's actually 2 kinds of steroid myopathies that you can get. One is called, they call it ICU myopathy. And what that means is when somebody's really sick, and this is not a myositis patient, you have a bad car accident or you get pneumonia. Sometimes they have to use really high dose steroids to help stop inflammation, like if you had inflammation in your brain when you had a car accident. And if you get that multiple days in a row, it can actually bother your muscles a lot and irritate them and make you get enzymes that are elevated and stuff like that, and get fat in your muscles. Then there's another kind of steroid toxicity where it's more of a chronic use of steroids. And what happens is sometimes people say, oh, you feel like you're more tired, you're weaker, and it's, you think, oh my God, it's my myositis, give me more steroids. The steroids are actually what's causing it. And so then we have to pay attention to that. If it seems like, we can't, like it doesn't make sense, right? It's not really following the pattern, more tired, fatigue. Sometimes your enzymes can go up with that, sometimes they don't, you just feel tired. The only way to know for sure, one is to take you off of it or lower it. Another one is you can do a biopsy again and you see a different effect in the muscle. You don't see all that inflammation, but you see the different muscle cells. Some of them drop out and get smaller, and so you can detect it that way. But it is something people have to pay attention to because your muscles can get quite fatigued. Like you're playing basketball and you're like, I just can't do what I used to do. But somebody would test your strength, and your strength might be great, but your function is off, right? You don't have the endurance that you used to have. Could be for your medicines. Also, another medicine we often use is Plaquenil. You've heard people talk about that. Plaquenil can help a lot with the skin. It can also irritate your muscles if you use it a long time. So you got to be careful. That's where somebody has to pay attention to. This doesn't seem right. Something's not right. It seems like you shouldn't be reacting this way. I wonder if it's your medicine that's doing it, not the disease. Could be.
It's hard to find a good doctor that pays attention like that.
And balances it. Yeah.
Because they just like, oh yeah, take more prednisone. No, it's just.
Well, that's where you have somebody who's at least periodically, and people do this. They live all over the country, but sometimes they'll go to see a myositis doctor periodically, like once a year even, or if there's ever a question, and then they get taken care of by somebody else close to their home. People do that a lot. They really do. I just want to show a couple slides on outcome. So some studies have looked at patients that started as juvenile myositis, and they looked at them many years later. This is one study by Adam Huber, which showed that when they looked later, that still about a third of kids had calcinosis, about 16% weren't as tall as they would have been. And what they found, though, is education and vocation and stuff like that didn't change. But what they did find is that still a significant amount said that they were having problems, whether it was rash, they felt weak. A lot still were on medication, and what we find is a lot of people still have pain. And it's unclear where the pain is coming from. Whether it's the muscle pain, or I showed you that picture of the calcinosis, is that calcinosis in the muscle causing problems? It's kind of hard to know, but that's something that shows up periodically. Another study, which is from Norway, where because of the whole country, they follow the patients forever, so they can watch people for many years. In the US, it's a little harder because you move around, you go from a pediatric doctor to an adult doctor. But they also followed patients, and now they followed them 25 years or so out from their condition, and found that some still had irritation of their muscles, some still had some weakness, a whole bunch had some damage, whether it's scarring on the skin from the rash or there's some scarring in the muscles when they looked at it. And so about a third had calcium. Now, if I think back 25 years ago, we're talking about, you know, in the early 90s, right? And really, we didn't start getting as aggressive as we do today until we were later in the 90s. So there is a difference, because when you were diagnosed, you said you were on prednisone. It wasn't until the late 80s that we started using methotrexate in the condition. And so that allowed us to use less prednisone, get people better controlled on methotrexate. In the 90s, we started using other medicines and adding IVIG to it. So I think overall, we can get more aggressive and hopefully get things controlled better with drugs that don't have as many side effects. Any drug has a side effect, but that one doesn't have quite as much. The other thing we know is that if you have this antibody like NXP2 and you were young, like under age 4, your chances of getting calcinosis are really high. But if you have the antibody and you're age 10 or 12, the chances are much less that you get that you have calcinosis. So we also know is how old are you when this starts? What are the chances that you're going to have some of these problems and side effects? The other is pregnancy and outcomes. So we do know that there are, you know, many young women who go on to have successful pregnancies. So there's little case reports. No one's ever really done a study of it. But some of them talk about flaring after you deliver, but often they believe that many of those women have some activity of disease. It wasn't totally quiet, and that makes it much worse when they deliver. Some people talked about many years ago that the babies that were born, half of them were premature, or half of them were a loss. They were some kind of a loss of the pregnancy. More recently, we've done some retrospective reviews, which means we go back and look at the last 20, or 30 patients that have had babies. And we do find that babies, when they're born, they're more likely to be premature and they're more likely to be small when they are born. And that's what increased risk for small for gestational age. And we noted that the women who had some activity of disease were more likely to maybe flare, get worse. The women that were in remission and had been in remission, they did not have a flare of disease. We also have to notice that if you were to get pregnant, being very cautious on the medicines that you are on, and that's where working with your physician, and particularly if there's a rheumatologist that focuses on pregnancy and autoimmunity is really important, because they know what are the right medicines for you to be on, if any, all those kinds of things to know what to do for you. A couple other things, I know this is a lot of information, but all I want you to see is the lines that show that this way is as time goes on, you see that these numbers go down. And this is heart function. So what was important is that if your disease continues for a very long time, it can start affecting your heart. Normally we don't think the heart is as affected, but if it goes over time, they show that the ability of your heart to contract really well goes down. And so that's one thing that we know. We also know that the rhythm of your heart, you hear about people with rhythm problems, that the disease can affect that. Particularly those girls that have that one enzyme I talked about, SRB, and that polymyositis, they get sick really fast and that kind of thing can happen. I want to talk about one other thing, and this was just one other study. So the rituximab myositis study, it was really the largest placebo-controlled trial that we've ever done. We had adults and peds in this study. And what we found, and what this graph shows us, is that as time goes on, almost everyone got better. The line going down means your disease got better, right? So it really worked. But what we noticed, particularly, is different groups of people got better faster and had a bigger change. And so what these lines really show you is that people with certain antibodies, like this one in red, they got 50% better within a few months, whereas the one in blue took, almost a year to get that far better. We also know that children, people with dermatomyositis, so I shouldn't say children in age treated, because we actually treated multiple adults that were diagnosed as children with it. They actually did better than the adults did. And it could be they maybe didn't have as much damage, but an adult maybe had it longer, maybe had more damage, but we know that they responded better. So there are even differences, and that's what I wanted to say. There's actually differences in how we respond to some of the medicines. Some of the adult medicines like Imuran, we don't usually use in children because they don't usually tolerate it well, and we don't think it works very well. And then we do other things in kids they don't do in adults, like using anti-TNF drugs, particularly in children who have like ulcers or something like that. And so that's my talk, and I'm happy you guys, please,
Is that you?
That is me.
Oh, okay, yeah.
A few years ago,
Yeah.
this is my friend
Okay.
who lives in North Dakota. This is a young man who came to see me, who they thought he had a brain tumor because he was so weak that he couldn't function and he was getting worse and worse and worse, and they just thought they couldn't find it. He could hardly swallow, he could hardly speak. And he actually went to see the neurologist where I was at, and she goes, oh, no, you need to see somebody else. You don't have a brain tumor. And she called me in to see him. And I was like, you have myositis. I could tell by his rash, everything. We did our tests, and within a few days, got him on medicines. And then a year later, I have a picture of him carrying his girlfriend to prom because he could actually do that. And it was just very moving to me to have that. So it was very cool. Yeah.
Yeah. Thank you so much. This was excellent. This has answered a lot of good questions for me. So.
Well, good. And I'm happy to answer more. I mean, this was it's kind of an unusual topic to talk about. So, and sometimes it's very personal. So I didn't know if there were other questions or things you wanted to talk about.
Okay, I don't speak English, so I'm going to make that question. And if I have calcium in my arms,
Yes.
but when I was 8 years, it is to take out now, or maybe to stay there? What is there?
So we believe calcinosis happens because there's active inflammation. And if it's continuing to grow, we think there probably still is inflammation there that's making them grow. If they developed, but they're not changing, they're just there, and if they're bothering you in terms of you can't move or they're painful, then there's a couple things. One is there is a medicine that's topical people use, and they think, so it's on the skin. And if the calcinosis is on the skin, some people swear after a few months it starts to soften it, and the calcinosis, and break it up. If it's on your elbow and stuff, it's on the tendons and stuff. Yeah, some people actually, plastic surgeons, sometimes will go in there and take a few of the pieces out. They can actually surgically go in, but you need someone who's very talented and knows the disease. So don't go to anybody, but sometimes plastic surgeons, and I don't know where you live, but there was a person at Mayo Clinic who used to work with me on it, and now I live in North Carolina and there's somebody there. But they would do an MRI and actually see where's the calcium. Is it stuck? Because you've got a muscle there and a tendon.
Yes.
And if it's in the middle of the tendon, they don't want to ruin your tendon. But if it's outside of
I
it,
need to ride.
yeah. Oh no, you need to be able to use your arm. But if it's on side of it, sometimes they can cut them out and then let it heal. And that actually sometimes can help quite a bit if it's really bothering you. But find the right person. Again, don't go to anybody, but someone who really understands, and have them work with your rheumatologist, because sometimes what I have them do is after the surgery, I give you like methotrexate or I give you steroids for a little bit to calm everything down, because it's going to make things kind of excited in that area, stimulate the immune system. Calming it down sometimes can help quite a bit. But it looks like it's hindering you, stopping you from moving and stuff. You can't,
Does it hurt?
No, but it's right.
you're stuck because of this. And so that you should, yeah. So that is something to ask about. Now, in the 80s, they said don't touch them because you'll make it worse, right? Which is a little bit true, but now that people can go in and they understand it enough, and technically they can sometimes help you so that you get some more motion in your arm. Yeah, sure.
I mean, I think you answered all the questions that
Okay.
I had really well. The myositis antibody profile is what I'm gonna look into.
Okay.
The muscle biopsy, and I think my biggest thing is I just wanna, moving forward, I'm looking for preventative.
Well, to stop you from getting worse.
Yes,
Yeah.
because like I said, for the past 10 years, it's been slowly getting worse.
Yeah.
And I find that anytime the doctor tries to decrease methotrexate, it's like, that's when I get hit the hardest.
And you take a back step.
I take
Yeah.
a back step, and then he
Okay.
has to increase the methotrexate. So about a month ago,
Yeah.
that's what happened. My
Okay.
arm became really weak.
Yeah.
And I've never had issues, I've ever had issues up here.
Okay.
And it came, so he had to go back on the methotrexate, increase the methotrexate, and I take 30 mg a week.
Yeah.
I take, and he had to increase the prednisone from 3 to 10.
Yeah.
So,
Have you added though, so one of the things is if you find that you're so sensitive to any of those changes, often I think most people believe that adding something else to help you calm things down even more is worthwhile. So for example, rituximab is an example of something you could be using, or IVIG is something you could be using on top of it. Not in place of, but on top of it. And by doing that, and what I tell people is like with rituximab, you give it every 6 months. You need to do it a couple times, so you need to get through like a year. And sometimes you notice you can start coming down on your other medicines without getting worse.
okay.
You actually can do better.
I'll try that. I'm on IVIG now, but I've been on it since 2009, and in the
Yeah.
beginning it worked well, but now it's not.
It's not working. So it might be very much worthwhile to try
I'll try that.
to go and to do rituximab.
I'll try that.
The other thing that might be very helpful for you is, I don't know where you were originally diagnosed, but if they had a muscle biopsy way back then, and you get a new one, people could look at both of those biopsies, because they usually keep tissue, a lot of places, keep it for many, many, many years. They could look and say, has it changed? Because you talked about things evolving, they could actually look and say, wait a minute, what was it like at the beginning, and has it changed?
I have a muscle biopsy.
You did?
Yeah,
Okay.
5 years. So
Yeah.
then we have the diagnosis.
Yeah, they diagnosed it then. Okay.
So they did it on my
Your thigh?
this
Yeah.
thigh, and they did it here.
Okay.
So
The
they-
same time or more recent?
This was first,
Okay.
and this was
Second?
second, so
Okay.
a few years apart.
Okay.
So do you suggest, because I get MRIs, and so do you suggest I should do another muscle biopsy?
Well, that's what I would work with your physician, because you might need to. If things are changing, you think the actual disease is changing, you might want to get another muscle biopsy to see why. So I would work with your physician on that.
Yeah, just somebody get cut, but if it's working, to see where I am.
Yeah.
Yeah.
It might be worthwhile to have that discussion.
So we're talking that.
Yeah.
I've tried a lot of things in the past, but that's what I'm going to ask you. If I've tried a lot of things in the past, like let's say about 20 years ago, and it didn't work, is there a possibility that could work now?
Yeah,
Because your
it
life
is.
changes?
Yeah.
Okay.
So, and sometimes like now we maybe use higher doses, like methotrexate, we go higher than we used to.
Okay.
And then like subcutaneous methotrexate works better than oral methotrexate. And it's a little tiny shot, it's a little needle that goes under the skin, so it doesn't really hurt, it just burns a little. So it actually works better than taking the pill, so it's more potent. And so a lot of people move to that, and then it doesn't make you nauseated either. I don't know if methotrexate does that to you, but it can work just a little bit better. So all those things sometimes can just help you that much more.
Yeah. Okay. Oh wow, that's great. Okay.
Yeah.
Yeah, a lot of things. That's what I need, just to play with whatever, so I will get worse. That's
Yeah.
the main thing. Yeah.
Well, and hopefully they can get you even feeling a little bit better.
Yeah.
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 So,
Okay. Yeah.
Awesome.
Thank you so
Thank you,
much.
guys.
This is great. Thank you
Thank
so
you for
much.
being here. Thank you.